Hi everybody, welcome to Education Week, and today is the first lecture. For the sake of this lecture, we're going to be recording, so I think I may stop the video in case anybody does have questions, but if you could hold your questions to the end, it would be appreciated. My name is Michelle, and I happen to be the Cardiac Rehab Manager. I happen to be a pharmacist, but my most important role is actually being the family member of someone who had her first heart attack at 53. At that time was diagnosed with diabetes, and at that time underwent a 3-vessel bypass. A few years later, she needed to have a stent, which is an angioplasty, and we're going to talk about that. And then a few years later was diagnosed with heart failure. A few months later developed atrial fibrillation, and a few years later required valve surgery. That is almost everybody in this entire class in one person. And as the family member of someone who had watched and seen and witnessed what this individual had gone through, I think I have some idea of what your family member is going through. May not necessarily be you, but what your family is going through. And that gives me almost empathetic and an understanding of what you're feeling. So this lecture is to address some of the concerns that you have about what is cardiac rehab and what you can expect during cardiac rehab. In our facility, we're going to have everyone wear masks. And during this lecture, I apologize, I'm not wearing a mask, but that's just so you can get a good recording, and that's why we're doing that. But in general, everyone will wear a mask. Everybody coming in class to exercise will be double vaccinated, at least. We strongly recommend that everyone get, it doesn't matter how many other boosters they had, but the fall bivalent booster is so important that you get that one. And you can have that discussion with your family doctor, the cardiologist, or the pharmacist, whoever you feel comfortable, but that is a strong recommendation by public health. We ask that please, when you wear your mask and you leave the building, I know the first thing you want to do is yank your mask off and throw it anywhere it's willing to go. But please don't leave it in the parking lot. Maybe put it into your recycling or your garbage bin at home. But we sometimes find these masks in every direction possible and no one wants to pick them up. So why do people come to cardiac rehab? And I just want you to know that this lecture is repeated in some ways in other talks. So you may find me giving you lots of information, but it is almost like we're adding to it with each lecture, okay? So some people come to cardiac rehab because they have angina. And who here has had angina? Put your hand up, or if you're in the chat field, maybe give me a thumbs up. Perfect. So we have one person in the room with angina. And what is angina? It's basically a warning sign you may be at risk of developing a heart attack. And it comes with certain symptoms, but it's when your heart is not producing enough oxygenated blood for itself. Okay, so that's basically what angina is. Who here has come to cardiac rehab because they've had a heart attack? Okay, so heart attack is also called a myocardial infarction or an MI. And there are different types of heart attacks, and we're going to talk about that more when we get to that part of the lecture. But it's basically where there's you've had some sort of angina, and you've got a sudden blockage, and basically that part of the heart is not getting enough oxygen-rich blood. And if it continues, the heart may be at risk of damaging itself or that part of the heart dying. Some people come to cardiac rehab because they have diabetes. Who here is diabetic? Okay, and I'm just asking this question, and there's always one person in the room that raises their hand for just about every part I say. And that person's smiling at me right now, and I know that there's always one special person, so I always say that you're special. Diabetes happens to be 3 disease states in one. It is abnormal blood sugar, it is abnormal blood pressure, and it's abnormal cholesterol. And I'm going to do an entire portion on just diabetes, and then we'll get into that. There's a separate lecture in your education week on diabetes, because diabetes is considered a cardiac risk equivalent. So what does that mean? Someone who is diabetic is at the same risk as someone who's just had a cardiac event. That's their risk of developing a subsequent event. So diabetes is a big deal. And when you're diagnosed perhaps with type 2 diabetes, all of a sudden the family doctor's sending you off to diabetic daycare. They're educating you, they're putting you on medications, and everyone's paying all sorts of attention to you, maybe more than you want. Having said that, we're going to speak more about diabetes. Anybody here with an angioplasty or a stent or a PCI, put your hand up. Okay, so we've got a couple people that have had a stent. And what a stent is metal scaffolding to keep your artery open. Okay, so keep in mind, it's inside your artery, but it's a metal scaffolding. And we're going to talk more about that in the medication lecture, and it will come up in other lectures as well. Who here has had bypass surgery? Okay, so how many bypasses did you have?
5.
5. The maximum number of bypasses is actually 11. David Letterman had 7. So keep in mind, when they do a sternotomy and they open it up, they open you up, and they're seeing, okay, where are the blockages? They've done a cath before that. And that cath shows up the narrowing of the arteries. And when that happens, they decide, okay, these are the vessels we're going to open up. And how I want you to think of a bypass is think of your artery as being the 401. There's a major accident or blockage. They'll take you off the on-ramp before, and they'll bring you on the on-ramp after. And that's basically what a bypass is, so that the rest of the heart will still be perfused, and they just avoid that particular blockage. Okay? Some people come to cardiac rehab because they have heart failure. And I'm going to use a model to explain what heart failure is. And then in the room, I'm going to pass this around. So a normal heart is about the size of a fist. And I've got these backwards, so I'm going to flip them around. Okay? They're all backwards. Of course, this is the day I'm being recorded, right? Okay. Yes. Okay. So I want you to think of your heart as being a two-sided pump. It's about the size of your fist. And what it does is when it squeezes, it's moving oxygen-rich blood through itself and then the rest of the body, and it's going through the different chambers. So what heart failure is normal heart pumps blood, and it goes through all the chambers. One with high blood pressure is one that has a thicker left ventricle. So I don't know if you can see in here, but the left ventricle is thicker. So the actual left ventricle is a smaller size. Okay, that's how it's usually caused by high blood pressure. So when we talk about changes in the heart due to high blood pressure, you don't feel anything. And everyone's all worried about you. You're being put on all these medications, but there's actual physical changes in the heart. And sometimes that LVH, or left ventricular hypertrophy, can result in a certain type of heart failure called diastolic dysfunction, which again is another lecture. Okay? But sometimes when you get damage to your heart and when you squeeze this thing, you'll see it, it becomes a baggy, saggy pump. And that's what heart failure is. So you can go right from a normal heart, have a heart attack, and end up with a baggy, saggy pump, which just doesn't pump as effectively. Does that make sense? That's what heart failure is. It's a pump that doesn't pump as effectively, so it's not moving the blood as effectively as it could. Okay? And what they noticed with heart failure is that, I'm just going to pass this around so you guys can squeeze them, because you actually get a good sense when you squeeze them. So there's normal on your very left. Middle one is left ventricular hypertrophy, which is a stiffer pump. And then the one on the right is the baggy, saggy pump. Okay, and you'll notice the difference and you have a sense of what it is. Okay, so what I want you to know is that heart failure will overlap another condition called atrial fibrillation by 30%. So 30% of people with atrial fibrillation will develop heart failure, and 30% of people with heart failure will develop atrial fibrillation. Anybody here with atrial fibrillation? Okay, so we've got one person in the room. And what that is a condition where your heart rate goes really, really fast. So the perfect heart rate is around 60 beats per minute. But when someone with atrial fibrillation, even sitting still, their heart will go racing, and they'll feel like they're having a panic attack inside because their heart rate could go up to 150 beats per minute. So we had a patient in cardiac rehab. He started sentences off, and we're watching him because he's wearing a heart rate monitor. and he's at 70 something beats per minute. He's midway through the sentence, he's at 150 beats per minute. And by the end of the sentence, he's at 70 beats per minute. And he has no idea his heart rate's all over the place. So he is going in and out of atrial fibrillation, and that could be called paroxysmal atrial fibrillation. But he is not aware of any of it. The problem with atrial fibrillation is that it puts you at risk of developing strokes. Because what happens is inside the atria, sorry, I'm using my model, inside the atria, by pumping so fast, what's happening is that it's developing clots. And the easiest path for the clot to go when it leaves the heart is straight up to the brain. And that's why the biggest risk of someone with atrial fibrillation is essentially to develop a stroke. And nobody wants a stroke. A heart attack, yeah, I survived the heart attack, but I don't want a stroke, right? Because I know there's big complications there. So having said this, what they've realized in the last 3 to 4 years is that someone with atrial fibrillation, if we exercise them, and it seems wrong because you're raising the heart rate up to exercise this person, will actually do better and will have less symptoms the more physically fit they are. So if you increase the fitness level or increase the strength of the pump, it improves heart failure, but it also improves atrial fibrillation. And you're going to see through my talk, there are so many things that exercise seems to do that they almost call it, it's like a magic pill, but it's the part that you put in. That's the important part, the part that you're part of. Okay, it's your solution to the problem kind of thing. Okay, so some people come to cardiac rehab because they've had valve surgery. And I'm going to use this as an example, but there are 4 valves in the heart. And how I want you to think of the valves as doors. Okay, so the door opens, the blood moves forward, the door closes, the blood fills in the chamber, the door opens, the blood moves forward. But sometimes these valves can be either stenosed or narrowed, or they can be, they're not functioning properly and they're leaky. When that happens, what happens is that the blood is going backwards. So the most important of the 4 valves is the aortic valve, because that's the last valve before the blood leaves the heart. So if that valve is narrowed or damaged or leaky, or it's not functioning properly, or it's a bicuspid valve, they may look at you to see how are you functioning. And sometimes people will require surgeries for valves. When you go to see the CV surgeon and have a valve procedure done, they will always refer you to cardiac rehab because they don't want you to have another sternotomy. Okay, they want you, once you fix the valve, they're in there, they're going to see if you have any blockages, they'll fix everything. But having that sternotomy is not a nice feeling. Like, it is a miserable feeling. So anybody who's had a sternotomy once goes, this is never happening to me again, right? And having said that, they'll refer that patient to cardiac rehab. So anybody in this room had valve surgery? Okay, so which valves did you have? Okay, the other one that's also important is the mitral valve. And you could either have an aortic valve, which is the sternotomy, which is the better way to do it because you open it up and you're able to fix everything and all of those things. Or you can have something called a TAVI, which is an angioplasty approach, which is through the groin, like they did the cath, okay? And they can do the repair through an angioplasty approach if for someone who is not able to survive an open heart procedure or maybe at high risk. So you could either have aortic valve replacement or repair, or have a TAVI, or you have a mitral valve repair or replacement, or have a mitral clip, which is again the angioplasty approach. Okay, so some people who cannot get the surgery or they're too high risk of developing the surgery will go for another procedure. The better one is obviously to get the sternotomy done and to have the valve repair. Okay, some people come to cardiac rehab for other. This is the good group. This is the group that nothing bad happened to them. They're at risk, lots of risk factors. We think you're going to have an event if you don't make lifestyle changes. So we caught you in time, nothing bad happened to you, and you have a lot of risk factors. Anybody here in cardiac rehab because they have just risk factors? No one? Okay, that's you? Okay, diabetes, okay. There's another group that could have long COVID, but likely if you have long COVID, you're doing your cardiac rehab from home. You're not doing it likely in clinic, because anybody with long COVID, that's 10% of people who develop COVID, will have something called long COVID, which is so debilitating that the big event for them that day is I went to the grocery store. That's it, I'm done. I'm done for the day. I just went to the grocery store. That's all I can manage. Okay? A very functional young person, if they develop long COVID, they have to do a lot of rehabilitation to get themselves back to where they were before they developed COVID. So that's why there's a group of people that will do it remotely and will work in cardiac rehab. There's another group that may have POTS, which is postural hypotension, or SCAD, which is spontaneous coronary artery dissection. Those are also people that come to cardiac rehab. So I'm going to ask this group online and in person, is there anybody in this room that had none of that? Because there's always someone that enters the room that just goes with everybody else and finds out, oops, I'm not supposed to be at this lecture. So, okay, all of you guys are supposed to be here. Okay, perfect. So, being handed the diagnosis of heart disease, you do not feel well, and you do not feel 100%. And for anybody who tells me I'm just fine, I'd be looking at you going, are you sure? Because some people just can't admit to themselves, hey, I don't feel good. This is not what it's supposed to be. So I want you to recognize that you can be anxious. You can be angry. How on earth was this supposed to happen to me? And why during COVID, when I can't even get everything else done, and now I've got to wear a mask and I've got to be at all these appointments? How the heck did this happen to me? And where was my warnings? Some people can be sad because the hormones released during your bypass surgery, during your heart attack, are the same hormones released during depression. So you may temporarily need some help. If you are not feeling well, please, when we ask you, how are you doing? Don't say fine. Be honest. I mean, we don't necessarily want you to vent at us, but we want some honesty. Like, think of us kind of like your priest or your like spiritual leader that's just going to ask you, you're actually just going to tell us the reality of how you're feeling. Some people are shocked, going, this was a big giant surprise, going, I had no warning signs. Some people are very stressed, going, Michelle, there's 40 appointments. That's crazy. You want me to spend that much time with you guys? That's insane. But in total, there'll be close to 40 appointments by the time you've done these lectures, by the time you come to classes, by the time you come to all your appointments with the cardiologist. There's about 40. So it is a commitment on your part. And you could be going, okay, I'm missing work for all of this. How am I supposed to manage? Some of you are worried. How am I going to pay my bills? Because, you know, some of you are young. We've had people as young as 18 to 25 and people as old as 90. That entire group of people are in cardiac rehab. And some people are relieved, going, this atrial fibrillation, these symptoms, they're not in my head, they're real. And that is reassuring, because otherwise I just thought I was a nervous person, and you're not. Okay? So all of these emotions, perfectly normal. And if you didn't go through some of them or all of them, I'd be asking questions, going, everything okay? So what is cardiac rehab? My goal today is to try and explain to you what cardiac rehab is. And basically it encompasses all aspects of wellness, including physical, dietary, emotional, sexual, work, and social reintegration. When I mentioned the sexual part of it, a little 83-year-old in cardiac rehab said to me, if you were going to have a sex talk today, I would have brought my husband. And I said, a little too much information for me. But at the end of the day, you've got to feel comfortable, because this is a big part of people's lives. And we are going to talk a little bit about that when it comes to that part of the lecture. So there is an introduction lecture, which is today. And we ask that everybody see the introduction lecture, because you have to know, what are your goals? What's my role in cardiac rehab? What am I signing up for? So that's why at least the intro lecture is important. But we also explain to you that there's an educational component to cardiac rehab. It isn't just, I'm coming here to exercise, because you could have gone to any gym if that was the case. Okay? Why are you doing what you're doing? So almost every lecture has an educational component. And we don't tell you what it is, because if one of them happens to be on smoking cessation and you're a current smoker, guess what? We're expecting you're not going to show up that day, right? So we don't tell you what we're going to talk about. And the goal is that you try and attend as many lectures. So there are certain lectures that are done outside cardiac rehab, which is part of Education Week. And I have a handout for all those lecture times. And then there's ones that happen in class. So every time you're exercising, there's something going on that's an educational component of it. It's almost like a 50-50 in terms of that's how often it happens, but there is that part of it. So there's people who are exercising or that are doing things online, and they're not getting the full benefit of what cardiac rehab could be. Now, our program was mentored by Toronto Rehab, which is UHN, and they have over 70 years of experience in cardiac rehab. And then our program is also it kind of in some ways matches, but doesn't quite mirror what St. Mary's does, because that's our nearby cardiac rehab facility. But we try to match. And so the programs stay very standard in terms of some of the things that they do. But it is a supervised exercise program, and you are in a gym with other people. And the reason you're in a gym with other people is because the idea of socialization, the idea that other people are in a similar situation to you. You're not in this alone, and that you can exercise in a safe environment and you will feel comfortable then exercising at home. So we ask you to come for goals when you come to cardiac rehab. Set your own personal goals. Most of you will say to me, Michelle, I am here because my doctor told me to show up. That's why I'm here. Okay, so I showed up. The reality is about 25% of people that are referred to cardiac rehab actually attend. Our goal is to make it higher. If we explain to you what you're going to get out of cardiac rehab, will you show up? Or at least try to attend some of the appointments? Because we recognize you can't attend all of them. So if you aren't able to attend, please let the girls know. Look at one or two in advance and say, yeah, I can come to this one, but I'm not going to be able to come to this one. I have a doctor's appointment, or I'm going to be on holiday, or whatever. Okay? So one is to understand your disease. You do not need to understand all of cardiology. One is to figure out your modified risk factors. What are your risk factors? I can't modify them if I don't know what they are, right? So tell me what my risk factors are. And one is to help you with strategies to help you with exercise, eating healthy, and quitting smoking. So this first lecture is an overview. I am not telling you everything, because if I tell you everything, you'll just go out of here going, way too much information. Okay, so this is your day-to-day cardiac rehab team. It's a pretty big team. Okay, 99% of the time there is a cardiologist in the building, 99% of the time. And if the cardiologist is not in the building, there's usually an emerge doc. And if an emerge doc is not in the building, and there's just that small percentage of time that may not be, we have 8 nurses. We have defibrillators, we have AEDs, we have a trained staff to supervise your exercise, so you can feel safe exercising here. In addition to that, I happen to be the complaints department, I happen to be a pharmacist, and I also happen to be the manager for rehab. So I've got a few tasks, so you may not always be able to get a hold of me, but if you can't get a hold of me for concerns, you would want to talk to Tony, who is our office supervisor. Alicia is our admin person who's booking, but you will realize there is 5 other team members. So when you call in, please say, my name is, and I'll use the example John Smith, because we have so many John Smiths in our systems, okay? John Smith, and my date of birth is, because in some cases we have up to 12 people with the same first and last name. And we don't want to mix you up and confirm a wrong appointment with the wrong person. So always say, my name is, and my date of birth is. And then continue your thing. And you can leave messages at midnight. We don't care. We'll take the messages off, and we'll be able to respond to them. In the gym, you have 2 kinesiologists who are Victoria and Chantel, and they're supervising your exercise, along with Laura, who's supervising the exercise, and she does some of the virtual cardiac rehab as well. As part of our nursing team that will do the intakes, you will see several of them. And Nina is involved in smoking cessation and smoking and diabetes counseling, but some of that may be done virtually. Okay, so having said this, we're trying to deliver our cardiac rehab program, and this is your day-to-day team, even though you don't see most of them. You may only see Chantal and Victoria most of the time when you come to classes. Okay, at this point pre-COVID, we would have had a cardiac rehab graduate talk to you. In every cardiac rehab conference we've ever gone to, they always had a cardiac rehab participant talk to an individual, talk to the team. Why? Because the patient is the focus. And we have to understand what you're going through. So I'll give you an example of a conference that I went to where the speaker happened to be a physician who said, when I retire, I'm going to climb a mountain. Now, he was talking about a mountain in Australia, not like one of the big K2 or, the one in the Himalayas or anything like that. And he said, guess what? I retired and I had a heart attack. So that did not fit well into my program. Okay. But having said that, within a year, he was able to climb that mountain in Australia. And the last 7 days, he couldn't have a shower because it was all snow. So it is a fairly big mountain that took 7 days to go up one way. Okay. So you can actually be more physically fit finishing cardiac rehab than you were going in. And that is our goal. Okay. So what Patrick would tell you, and he's our cardiac rehab graduate, is he would tell you, ask questions. Because if you don't ask questions, are you actually taking in things? Okay? Are you engaged, or have you tuned out because I've talked to you for more than 20 minutes and you're going, I'm done now. Okay? So ask questions. The second thing Patrick would say to you is have fun. If you're not having fun, exercising at home becomes a big, long ordeal. So we would ask you, when you're exercising, involve another family member. It may be, if your family's not ideal to exercise with, maybe a neighbor, maybe involve a dog, but involve somebody else that will encourage you on a day that you're not up for exercising to go out, because they'll be, I'm here, so let's go. And you're going, I don't really want to go. But you'll go anyways. And then you're going, I'm glad I went, right? So sometimes when you start exercising, you're not in the mood to go. And you're just like, I'm in my miserable day, just leave me alone, right? But if you do it, you will be happy you did it. So that's the third thing Patrick would say. And then he would ask you how everyone's doing. So that's Patrick's talk, okay? So we'll start off the lecture by talking a bit about what is the heart muscle and some definitions. So when you think of the heart, you think of it as a two-sided pump. It is about the size of your fist, okay, as a model. So everyone's a different size, so think of it as about the size of your fist. It's a hard-working muscle that contains an electrical conduction system, but it's pumping 4 to 5 liters of blood during rest and every minute while it's working, all the time. Okay? When it does this, it's supplying nutrients and oxygen-rich blood to itself and other parts of the body. When it's supplying itself with the coronary arteries, which you can see in here, the arteries inside the heart are called coronary arteries, okay? And they're responsible for supplying oxygen-rich blood to the heart itself. So I want you to think of the arteries as being a straw, and inside the straw is where the blood flows. If that straw starts to build up plaque alongside of it, then what happens is that's called atherosclerosis, when the plaque builds up inside the artery, okay? And this results in the narrowing of the arteries. And if it happens in the coronary arteries, it's called coronary artery disease. Everyone's with me so far? Okay. First question. Adult learning principles say if I talk at you, you tune out. If I engage you, then maybe you stay with me in this. So true or false, and you can answer, and you can be absolutely wrong, and it doesn't matter. Plaque builds up and atherosclerosis begins with old age. True or false? Okay, we have a very smart group in clinic. It actually begins at the age of 2. Imagine that. Your mom was right. You are what you eat. So you start off with first, second, clean arteries. Nice and clean. Over time, it builds up. But remember, some people with bad family histories can develop coronary artery disease. And we've had people between 18 and 25 with their first heart attack. Okay? But typically males in their 40s are going to start to see signs of coronary artery disease. But some people with bad family histories can occur earlier. Second question, atherosclerosis affects only the heart. True or false? False. Smart group. So it can affect, remember, your one giant set of plumbing, all arteries through the body, blockages going up to the neck, towards the brain, can result in an ischemic stroke. Blockages going down your legs can result in peripheral artery disease. But remember, peripheral vascular disease or peripheral artery disease is actually worse because those arteries are much bigger. Okay? And if they're blocked, think about how bad your disease is. And you can have blockages in your heart and that can result in angina, a heart attack, or sudden cardiac death. Now, anybody having a bypass that has multiple vessels in just your heart likely has blockages elsewhere. Okay? Think about it, because you can't just have, oh, I'm just going to have blockages here. Forget about the rest of the body. So keep that in mind. And diabetics are more likely to have also peripheral vascular disease. So peripheral vascular disease tends to be more with diabetes. It tends to be sometimes more with smokers, and it tends to be in certain other disease states. What sudden cardiac death is it's a rhythm disturbance. So coronary artery disease can present in different ways. Now, what are the signs and symptoms of angina or heart attack? Anybody? Sweating is one of them. Go ahead. I just put it up there, sorry. Dizziness is one of them. Chest pain.
Yeah.
Okay. Discomfort in other areas. This is a very tricky one. So the area is from the nose to the chest. Anywhere in between is considered heart disease until proven otherwise. So do you remember the family member I told you about? And I tell stories when I talk, so people remember my crazy stories. Okay? My family member was female and diabetic, and they present with atypical symptoms, diabetics and females, and or females. Her angina equivalent was ear pain. So she would bring out her nitro spray when she had ear pain, and that was her angina equivalent. So you could have jaw pain, you could have arm pain, you could have pain radiating the back, you could have an elephant sitting on your chest, you could have a squeezing pain, you could have a sharp pain. All of those are signs and symptoms of angina. So the question is, what's your angina equivalent? When are you bringing out your nitro spray? That's the question. Okay, so keep that in mind. It doesn't always present in the same way for everybody. And lightheadedness is also one of them. So, do you have to have all these symptoms? No, you can present with just shortness of breath and have what they call a silent heart attack if you're diabetic. And you didn't even know you had it. You presented with shortness of breath, you went and got some testing done, and they said, oops, did you know you had a heart attack? And they're going, when? I didn't know, right? So keep in mind, you don't have to have all of this. Now, what is a heart attack? So we're going to go back to this model here. This is you at birth, and over time, this is you when you start to develop the signs and symptoms of angina. So I don't know if you guys can see this. You're here with certain blockages. And then when the doctor says, we're going to put you on cholesterol pills, and you're going, doc, let's talk. I'm not one for pills, right? And they're looking at you going, no, I really think you need to be on pills. And you're going, no, let's talk. And you're going, but your blockages are this big, right? That's when you're starting to get symptoms of angina. That's your warning sign, but you've already lost a lot of the artery. So keep in mind, we're having that conversation. So part of the plaque breaks off, it goes to a smaller artery downstream, and basically it blocks the blood flow. When it does that, part of the muscle can get damaged, or part of the muscle can die. Now at this point, I probably should explain to you, because someone called me a Debbie Downer. She goes, Michelle, you talked a lot about death. And that's kind of a bad thing to talk about. But what cardiologists really care about are four main things, which are called major cardiovascular, adverse cardiovascular endpoints, okay? They care about death, they care about heart attacks, they care about strokes, and they care about hospitalizations. Do they care so much about nausea, vomiting, and diarrhea? Not really. We'll work through those symptoms. Don't worry about those. Those are side effects. We'll work through those. But they care about what keeps you alive. The number needed to treat to save a life. The number needed to treat to prevent a hospitalization. The number needed to treat to prevent a death. So when we talk about a heart attack, there's many different types. And I want you to realize COVID is a separate third type. This is not the only two types you can have. So you have a larger vessel fully blocked. That is called a STEMI, or an ST elevation MI, or myocardial infarction. And that's a large heart attack. Okay? That's a large vessel, fully blocked. It is more dangerous. If someone had another type of heart attack called an NSTEMI, that's a smaller vessel, partially fully blocked, or a larger vessel, partially blocked, putting you at risk of developing another event. And that's when you get the troponins and the elevation in hospital, and they tell you you've had a heart attack. And you can have multiple heart attacks, right? So when you have a heart attack, the key is which type of heart attack did I have? You need to know. So delay can be deadly, and waiting to get to the hospital, especially during COVID, going, I think it's a bit of indigestion. I'm not 100% sure. I'm going to take this and see if it goes away. Or it's 4 a.m. I don't want to disturb my wife and call 911. Or, my son's at work. I'll wait till he comes home and then he'll take me. No, you need to call 911 and go to the hospital if you think you're having a heart attack after you use your nitro spray and if it's not relieved within 3 sprays, okay? We don't want you to wait more than a few minutes. Before COVID, I would say twice a week, someone would come here with an emergency chest pain because, I don't have to wait if I go here. I would all have to go to Emerge, but we don't have that cost-busting medication that you would see in Emerge. So we ask you to call 911. And don't go to your family doctor. Again, they don't have those emergency meds and you're just delaying the transfer. What we want you to do is call 911. Now, we had a patient sitting in here in cardiac rehab pre-COVID that had his heart attack. He was a truck driver in the States. He had to go 17 miles by ambulance. It was not just a heart attack, it was a cardiac arrest as well. Okay? 17 miles by ambulance. His bill was $1,700 US. So I say you get the deal of a lifetime because you're paying about $45, but you save on parking. Okay? Having said that, time is muscle. If you think you're having a false alarm, okay, we're okay with it. It's okay to have a false alarm. When you call 911, when the paramedics get there, they're contacting the hospital, they start treatment en route, the doctors are aware that you're coming, and remember, time is muscle. So it is important that if you think you're having a cardiac event, to go to the hospital. Now remember to unlock your door, because if your door is locked and you call 911 and then you don't answer your door, guess what they do? Yes, and then you have 2 problems. Right? So make sure you have your med list ready, and maybe you have that emergency preparedness bag or whatever that you have, but make sure you've got your med list and a problem list. Okay? So how big is the problem of heart disease? It is still considered the #1 killer worldwide. More than 12 million deaths annually, even during COVID. Heart disease was still more. Okay? And some people unfortunately stayed home because they didn't want to go to the hospital, and they had poor outcomes because they stayed home. In the last 30 years, declines in the amount of people, like the percentage of people in developing countries, because we're more aware of diet and lifestyle changes, but it is increasing alarmingly in developing countries such as India and China, because they're moving more towards fast food. And that the increase in diabetes and all those things are happening in those developing countries. Your question is, why me? How was I so lucky to develop heart disease? The first answer is genetic. Your parents gave you gifts. Your parents gave you genes from each of them. That's where you got your heart disease from. Okay? It runs in your family. So typically, if you think back, there's got to be some family members that have heart disease, unless you're a new diabetic and there's no one in your family history that has had diabetic, and they were all farmers. Right? Because for some reason, farmers live till 90 because they exercise so much, right? So genetically, you are predisposed to developing. Does that mean that it is an automatic? Not necessarily. Poor management of fats, you don't handle your cholesterol as effectively as it should be handled. Metabolic syndrome, it's belly fat, but we're going to talk more about that. Urbanization, we're not meant to be living in big cities, city of Cambridge, rural communities. We're not meant to be here. We're meant to be hunter-gatherers genetically, and we're meant to be farmers. We're meant to be moving. So for anybody online, I would say to you, when listening to this lecture, you do not need to be sitting. I do not get upset if someone starts walking on the spot, because oftentimes when I do this lecture and I do it virtually, I'm standing up and doing it. So you can build in steps. And I often tell people while watching TV, if you don't achieve your step count for the day of 10,000 steps, well, get up during the commercials and walk around, or walk while you're watching your favorite show, or if it happens to be the news, you may really want to walk then because it upsets you, obviously. So sudden change in lifestyle and this idea of being sedentary. We're not meant to be truck drivers driving for 8-10 hours a day, or maybe even more. We're not meant to be sitting at a desk working on computers and not moving around so much. So we do need you to be a little more mobile than you normally were before. So if we had to get to risk factors, there are two buckets I want you to think about them. There's ones you can do nothing about, so you just have to be aware of them because you can't change them. And then there's the ones that you can change. So the first one is you can't change any of these. Every year you have a birthday, every year until you start cholesterol pills, your cholesterol is accumulating. Okay, so age is automatic. Males typically over, we're going to take questions at the end. Males typically over the age of 45. Females postmenopausal. So menopause for women catches them automatically up to men, and menopause can occur earlier than 55 years of age. Okay, so having said that, whatever menopause occurs for that woman, she's caught up to a man now. And it's the estrogen that was protecting her before that. Male, an automatic risk factor. Certain cultures are at higher risk of developing heart disease. Okay, genetically, they're just more pre-wired, and that's typically because they have smaller arteries. And that may be First Nations, African descent, South Asian descent, and Arabic. Within 5 generations, they're automatically at higher risk. And you will see when I talk about waist measurements and BMI, they're lower. Their numbers are not the same as someone who's Caucasian. The last one is very important. Family history. This is a doubling of risk. This is not an equal risk factor. This is where you realize, oops, I've got this great gift coming to me. And you need to be open to the fact that maybe I need to make more changes than my spouse or the person sitting beside me because they're not genetically at risk. I am, because I've had family members that have had heart disease. This is the most important one that I'm going to talk about, and I'm going to say one point, and if you remember nothing about this lecture, it's the next point I say, okay? 90% of your risk of coronary artery disease is modifiable and controllable by you. That's 90. I will repeat this again. I will repeat it at the end of this talk, and I will repeat it again in another talk as well. So keep in mind, what are the things you can control? You can control your high cholesterol. We'll talk about all these risk factors: smoking, high blood pressure, diabetes, obesity, alcohol, physical inactivity, and stress. When we talk about stress, I want to talk about the concept of stress and distress. A person, and I'll use the example of that fire in Lytton, BC. Remember the entire town burnt down? Well, everybody's in the same boat. Some people, the first day, most people will be sitting there going, oh my God, how could this happen? And they're holding their head. Well, the second day, some people will get up and make a list going, okay, well, I can't really stay here, so I got to go find somewhere to stay. And I've got to call the insurance company. And then I've got to find, I've got to find a place to charge my phone. I've got to do this, and this, and they make a list. What I can't achieve that day goes to the next day. What I can't achieve the next day goes to the next day. But everything in my head, instead of sitting there worrying about it, is on a piece of paper. It's out of my head. It's on a piece of paper. I'll get to it. What's the highest priority? And I'll do it. So stress can be a motivator for some people, but for some people, they're holding their head and they just can't function. They're in bed, they're completely debilitated, or they're just worried. They're just ruminating of things in their head. Okay, and they can't function. They can't sleep. They can't do anything. That's distress. It's the same set of circumstances, but it's one person can function and one person can't. Most people are somewhere in the middle, where they're on this continuum where they can partially function, but they're still overwhelmed by certain circumstances, right? Where in that are you? And there is a full lecture on stress management because everybody benefits from some degree from that talk, especially during COVID. Okay, so let's talk about cholesterol. Cholesterol is a very vital part of your body and it circulates in your blood. Too much cholesterol forms plaque and then blocks the arteries, but typically there are no symptoms. Remember I told you, you're sitting between here and here before any symptoms of angina happen. And you're going, how on earth did that happen? Why was I not being warned? Where's cholesterol coming from? If I had to tell you 65% of it's genetic, these are the gifts from your parents. Only 35% is you control what you stick in your mouth. And by the way, no one is force feeding you to eat anything. You're choosing what you choose to eat. And you're going, yeah, but certain things are better for me. I like these things more than I do others. Yes, we have all likes, but sometimes we have to change our diet and convince ourselves we have to like other things, right? So typically cholesterol and saturated fats come from animal products and meat products, but remember that's only 35%. The other 65% was completely genetic, okay? When we talk about cholesterol, remember, you always have access to your own blood work. And when you go for blood work, you can get your results back. You can look up your own results. They tell you what normal is, okay? And you can see where your LDL lands. LDL in Canada is not measured. It's a calculated number because there are 4 subtypes, and we don't tell you which is the worst of the worst. So it's a calculated number because there are 4 subtypes. But your number for LDL has to be under 1.8, or we keep putting more pills on you. We have to drop you by 50%, and then there's more numbers. If we can drop you to less than 1.4, 2 heart attacks saved for every 100 people who've had a previous event. So even lower than that, even better. Okay? And it's your bad cholesterol. So LDL as low as you can get it. HDL as high as you can get it. Typically for females, it's above 1.3. For males, it's above 1.1. But this is typically only increased with exercise. And for most people that have had a cardiac event or bypass, it's the mismatch that your HDL was too low. That doesn't matter what your LDL was, your HDL is too low. And what's going to bring it up is a leaner body weight, increased exercise, and that's what's going to get your HDL up. And that's the part scooping out your bad. So your HDL is your garbage truck. And the question is, if you're working with a 0.8 HDL and you're supposed to be above 1.1, you're working with a teaspoon. You're not working with a big shovel. So that bad cholesterol is coming down, like you think of it like a faucet, and you're just working with a little teaspoon. You can go as fast as you can, but you're never going to catch up. You need to increase that to a big shovel. That means it's exercise. Okay? And it's what's carrying out your bad. Typically, it is higher in women. Now, typically we test cholesterol once over the age of 20. But if you come to cardiac rehab, guess what? We're testing it a little more often. So good news, you'll figure out what it is. And when we'll talk more about this in the medication lecture, there's a little more depth to this. I'm just kind of doing the surface for you now. If you drop your cholesterol by 10%, you decrease your chances of having a death by 20 to 30%. So what did I mean? If your LDL was supposed to be less than 1.8, it starts off at 2.5, and I drop it by 10%, 1 decimal place, I drop it by 0.25, I've decreased my chances of having a cardiac event by 20 to 30%. That's pretty big. And that can come with various means. So who here has used tobacco products in the last 6 months willing to tell me, including marijuana? And it's perfectly fine to use marijuana because it's legal, right? Okay, so some people don't feel comfortable, but for those people who've never smoked, you need to realize in 7 seconds, you feel amazing. Nothing except cocaine makes you feel good in 7 seconds. Okay? It is extremely addictive. In 7 seconds, you have your aha moment, you're calm. You have an appetite suppressant, so young girls will use it to stay thin. If you're a truck driver or you are someone that smokes all the time, well, it's an appetite suppressant, or it's actually something that alerts you. So you can go without having caffeine, and you can drive for 8 hours straight if you just keep smoking. You don't need to stop to pee. You haven't drunk anything. So there's a lot of things that cigarettes do that make you feel fantastic. And for some people, they'll describe that as being their best friend. So if you ask them to stop, you're just asking them, you want to take my best friend away from me? Why would you do that? But cigarette smoking has over 7,000 chemicals, 70 of which are known carcinogens. So I've got this on here, and it used to be 4,000, but now we realize there's 7,000. So this is a very well-crafted device. And it's got things like arsenic and white ant poison and carbon monoxide and insecticide DDT and cyanide and lead and toluene, which is an industrial solvent. All of those things are in a cigarette. You're going, why are they in there? Because that's the delivery system. Nicotine itself is not a problem. So we can get people off of cigarettes by giving them clean nicotine in the form of nicotine replacement therapy and other medications, because some people's brains are wired for nicotine. Okay, and if you're wired for nicotine, that's the only thing that's going to make you feel good. It's just not going to come to you in 7 seconds. So when we look at every cardiac rehab program has a smoking cessation program or smoking reduction, the key is to avail yourself of it. And if you don't find that we're the best match for you, certainly a lot of pharmacists are doing it, and a lot of family doctors are willing to help you to decrease or quit your smoking. But the most important thing, if you are a cardiac rehab participant, is to look at, how do I decrease this? Okay? So what happens when you smoke? Well, you have transiently an increased blood pressure. Cigarette smoke decreases your HDL. It damages your artery and blood cells, and it is predisposing you to diabetes. It's increasing your risk of a heart attack or a stroke, and it's putting 7,000 chemicals, 70 of which are known carcinogens. Now, some of you will say, well, I stopped smoking, but I'm vaping. Vaping is no better for you, unfortunately. It was just moving one to the other. And because of vaping, a lot of young kids are getting addicted right now. So the key is to look at clean nicotine and give it to you in another way, knowing that it's not going to be in 7 seconds, but it'll be able to get you off eventually. You may always be wired, and something may always push you back. So having said that, if every cardiac rehab program has a thing, and there are things that will push you towards, maybe it's a death, maybe it's an accident, maybe something awful happens to you, and you'll reach for the cigarette. So the key is to see if you can get help in that. And what's most effective is if you try quitting smoking by yourself, there's a good percentage, I think certainly 5 to 10% will absolutely be able to quit, no problem. They just say, I'm stopping, that's the end of it. About 30 to 50%, if they use smoking replacement or smoking cessation medications, will be able to quit, or they use, and then if you use some sort of program where it's structured and you get that guidance with smoking cessation, up to 70% are effective. So the key is it's about 3 to 7 quit attempts before you're most effective and can quit smoking. Typically it's 3 to 7. And it's not that it's not well intended. Everybody who had a heart attack said, I quit smoking right now. And then something will push them back. And you're most likely to start that again within 6 months. Okay? Now, let's talk about marijuana, because that's important. Marijuana is legal. And what I need you to realize is that if you're smoking a joint, there's no filter on it. It's actually worse for you than a cigarette. So we ask that it goes through water at least to decrease some of those toxins and that particulate matter that's going to damage your lung. But really what we'd ask you is to use edibles. Considering that edibles are not within 5 to 7 minutes or within 15 minutes, but it's going to kick in at around 30 minutes. So does everybody remember the 2 police officers that ate 3 brownies and then ended up calling 911? And they were working at the time? Yes. So this did occur about 2 or 3 years ago, maybe longer than that now. Having said that, if you are using edibles, keep in mind, we don't want you driving, we don't want you having alcohol, and we don't want you doing any work at the time, because it could put you at risk. And you are still considered under the influence, even though you haven't hit that alcohol level. Okay? So let's talk about blood pressure. The ideal blood pressure is 120 on 80. And when you come to cardiac rehab, you will know your blood pressure. Now, some of you are saying, Michelle, I am even better than that. I am under 120 on 80. And I would say to you, that's because we put you on meds. And oftentimes it's a heart failure patient because we put them on so many meds. And when we do your medication lecture, you'll see why you're at under 120 on 80. It's because we put you on meds. Typically, most people are not. Okay? So home monitoring, very important. But when you monitor your blood pressure at home, what we need you to do is void first. Okay? Because if you have a full bladder and you measure your blood pressure, you're raising it because you have to go to the bathroom. We ask you typically would ask you to sit quiet for a while, having taken your medication, so that your readings are lower after you take your medications, and that you haven't had any caffeine or you haven't had any cigarettes for at least a half an hour. Okay? But you would have to keep your hand at heart level, and there's a whole bunch of other instructions, but you'll be doing that in clinic, so you'll have some practice there. With high blood pressure, they call this the silent killer. Nobody feels anything. And then the doctor says, you have high blood pressure. And you're going, okay, what does that mean to me? I don't feel anything, right? And then they start putting you on medications. But typically, those medications stay on for life. And then they keep adding, because as you age, medication, your blood pressure goes through some changes, and it ends up being that your arteries will stiffen and you'll need to be on more blood pressure pills. So typically there's diet, medications, weight loss, exercise, and salt restriction. The salt restriction is key, and the diet is the DASH diet, which does not contradict the Mediterranean diet, it does not contradict the diabetes diet, and it's always considered either the number 1 or number 2 diet in the world. So this is a proven diet that the NIH contacted 5 universities and said, here's a year, give me the best diet. And this diet said that you had to increase more lean meats, more vegetables, some nuts, but unsalted. And there were certain things that you had to do in the diet. But typically, and it's 4 vegetables a day. So 2 with lunch, 2 with dinner. So I basically told you what you're eating by the time I'm done telling you the diet. And it's, I don't know if you've seen it, but it's a triangle. Anyone seen that picture? There's a triangle, and then the other side has the DASH diet. Okay, anyways. So the key with high blood pressure is that you don't stop taking your medications unless you talk to your doctor or pharmacist first if you're having problems with side effects. Diabetes. There's a couple people in the room that are diabetic. And what I need you to understand is it's 3 disease states in one. I said this once before. It's abnormal blood sugar, abnormal blood pressure, and abnormal cholesterol. But it also is a coronary risk equivalent, and you're put 2 to 3 times more likely to develop a heart attack or a stroke. You're also more likely to die of a cardiac event, and 80% of diabetics we know are going to have this. Obesity. I want you to think of it like you're packaging. So if you're 6 foot tall and 180 pounds, a little bit boxy. 180 pounds and 5 foot tall, you're boxy. Okay? Having said that, a BMI above 30 is considered obese, and you are at higher risk of developing a whole bunch of disease states. So 2 to 6 times higher risk. And typically we're looking for height and weight to get your body mass index. Now, all of you will have, I call it a report card, but it's your initial consult. And in cardiac rehab, we have this. Your family doctor, you can certainly get it from her. And I know here, if you wanted to get a copy of your report card or that initial consult, this information is all on there. Okay? But I would say to you, if you can wait, or if you want to get it to just keep it on file, it's fine. I call it the report card, but really it is the initial consult with the nurse or the doctor that you met with when you first came to our program. That's your starting point. At the end of the program, you're going to have another report card. But the reason I think you should always have this report card is this report card is one where 5 years from now, are you going to remember what vessels it was? Are you going to remember where your stent was? Are you going to remember the date of your event? You're not going to remember all of this. And if your family member had to ever explain it to you, I don't know if they could. I mean, to a doctor, I don't know if they could. Like, if you couldn't communicate with the doctor and your family member had to explain everything, they can't. So sometimes we recommend that people get a copy of this. I think in the front, if you ask for one, they may just give you a standard fee, but you would have a copy of this. And this allows you to go to Emerge and explain everything, because all of your cardiac disease is on, on 2 or 3 pieces of paper. So when we talk about packaging and body mass index, we talk about the pear-shaped and the apple-shaped. So you ideally want to be a pear-shaped, which is a smaller waist. And when we look at waist measurements, this tape measure is actually in cardiac rehab, okay? There's a little man and a little woman on here. So you look for the dress or you look for the man. So if you're a Caucasian male, which is most of the people in this room, your waist measurement has to be under 40 inches or 102 centimeters. And some of you will say, Michelle, I've never been there. That's okay. That's your starting point. You just need to know you're heading in the right direction as opposed to the wrong direction. And if you're diabetic, typically the weight is going to want to go on the belly, because that's where it tends to want to go. If you're of a South Asian descent or that high risk group of being the Arabic, the Native American, or the African descent, your waist has to be under 90 centimeters or 35.5 inches if you are male. Now, if you're female, different measurements. Your waist, if you're Caucasian female, has to be under 88 centimeters or 34.5 inches. And if you're South Asian descent, under 80 centimeters or 31.5 inches. And you're going, why is that happening? Well, life's not fair, and I'm just telling you what the rules are, okay? But this is your starting point, and you can measure your waist. Now, remember, when you measure your waist, it's not where you're wearing your belt. It's where the belly button is. So it's the part that sticks out the furthest. And male pattern weight gain is belly fat. That belly fat is active fat. It is actually sending signals to your brain to tell you to eat more. It's pushing against your liver, it's pushing against your pancreas, and it's causing abnormal numbers. Okay, it's causing abnormal signs. And it's doing this through hormones. Okay, hormones are signaling what you need to do. So sometimes when you gain weight, it's harder for you to lose because you're predisposed to wanting to eat more. And there's different sort of guidance in different sort of areas. But when you start exercising, one of the keys is that exercise is an appetite suppressant to some degree. Later on, it causes you to want to eat more, but at the time it is. Okay, so let's talk about alcohol consumption. We talk about the 2-4. No more than 2 drinks a day, no more than 4 days a week. You can't decide it's that fantastic Super Bowl party or the Raptors won the NBA Finals. Never going to happen again, Michelle. So guess what? All 8 drinks in one day. It's Thanksgiving, you know. It's New Year's. It was a great party, Michelle. I had all my 8 drinks in one day. Can't do it. Okay, some of you have had a stent and you're on 2 blood thinners and you cannot be on that. So if you're told you're on a blood thinner, and most of you will be on at least 1, but some of you are on 2, you have to watch your alcohol content. The new guidance, best, is actually none. And you're going, that's not a fun thing. How about just even 1? So if you go out to a party, maybe start off with a glass of water or maybe a coffee or tea or something like that, and then switch over because you can't have as much as other people in the room. Okay? Physical inactivity. I love this slide. This is all of us at the start of cardiac rehab. Baby steps. How much do you want me to exercise? How far do you want me to walk? How many times a week do you want me to do this? What's my optimum aerobic heart rate? What running shoes am I supposed to have? All you need is a water bottle and running shoes. That's it for your gym equipment. Now, we had a person who was 90 years old, didn't have a gym in her apartment building pre-COVID. She'd walk across the hallway, down a flight of stairs, 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 take the elevator back to the 19th floor and start all over again. So walking can be a form of exercise. You don't need to join a gym. We don't want you to spend the money because for some people, the budget's not there. Okay? Another person lost 66 pounds walking at Cambridge Mall pre-COVID, but it can do it now. When the mall was closed, we're not shopping. Right? You don't need to know all the sales. Someone's going shopping, just reach me at Cambridge Mall. Why do I like Cambridge Mall? First of all, weather's perfect inside. You just have to get close enough. Okay? You don't have to worry about parking if you go off hours. At 6 o'clock in the morning, only happy people go there. The sad ones don't make it, right? Bathrooms, benches, water fountains. What can you go wrong? And it's an indoor track. So there are people who do mall walking at Cambridge Mall. Okay. There's also a church, Forward Church, that has an indoor track. They may charge outside regular hours, but 9 to 11 if you wanted to walk there. I think they have not weekends, but they have it's free, or you can donate whatever you want. So there are different places for you to walk, and you don't have to feel like, oh my God, I'm living in an apartment building. Where do you want me to walk, Michelle? And I don't need to go out and buy a gym membership and all this other stuff. So what are we expecting you to do? Aim for 7 days a week, aim for 1 hour. Now, some of you will say, I just got out of the hospital. You want me to do 1 hour in 10-minute increments? Absolutely, do 6 of it. That's perfectly fine. Achieve 10,000 steps a day? Perfect. I have an impulse buy, a Fitbit. That's not reasonable for some people. It's not in the budget, okay? But some of you have a pedometer on your phone. Some of you will have a $10 pedometer that you could buy at I think Canadian Tire or some other places. You reset it to 0. Now what I like about a Fitbit is that it puts out balloons when I hit a certain amount of steps. And I'm like, okay, I can stop now. And it buzzes. So that's it. I wait till I buzz and then I keep going otherwise. Like I'm sitting there going, oh my God, it's 10 o'clock and I haven't achieved the 10,000 steps. So I'm sitting there going, okay, I'm watching my TV and those steps are going to go. Okay. But typically it's minimum of 10,000 steps. 14 to 16 is going to get you some weight loss. That's what you have to achieve. Higher than that is even better, but you may have to build up and wait for them in cardiac rehab to tell you what you're supposed to do. What's your target heart rate? We do not expect you to buy complicated machines. We don't want that. We don't want you saying, oh my God, she wants me to exercise 7 days a week. I've got to go join a gym. I've got to do this. This is going to be expensive. It's not in people's budgets. And we recognize that. And when you look in our gym, you'll find there's no expensive equipment. We don't want you to thinking, I've got to have bells, whistles, and sirens and everything. None of that. Okay? Now, when you first start exercising, some people are not feeling good and they are feeling down. If you have any mental health concerns, if you are depressed, you're going to find it a barrier. You're going to make excuses not to show up to cardiac rehab. Within 3 weeks to a month, I swear to you, everybody leaving that room, I mean, pre-COVID, because I can't see your smiles, have a big smile on their face and they're out of here. I'm done. I've done my 1 hour. I'm free for the day. I don't know whether it's that or they're starting to feel better. But exercise releases happy hormones called endorphins. So that person running outside when it's -10 and they've got practically icicles on their beard and mustache or whatever is doing it because they've got happy hormones released. And when they start jogging and exercising regularly, you will literally feel yourself off if you don't exercise that day. And you'll say, something's off. What happened? And you're going, oh, I didn't exercise. But when you get into that pattern of starting to exercise every day, you will feel that change. And you will notice the difference in your group of people that's exercised because they are coming in with more smiles. So cardiac rehab does break this negative cycle. Risk is a continuum. Risk is multiplied by small little risk factors. It's not big whopping things. It's small little things that are adding up. So we ask you to know your numbers. Figure out what your cholesterol is. You want your total under 4, LDL under 1.8, but Canadian doctors round up to 2. You know the number is 1.8. So when you look at your LDL numbers the next time, or you get blood work done, you can certainly ask, what's my numbers? HDL above 1.1 if you're male, above 1.3 if you're female. Triglycerides under 2. At this point, we're going to have a small little discussion on your sex talk. And this is when can I resume normal relations with my partner, not the extracurricular, okay? So there's a 4-page handout, doesn't have any pictures, but it gives you some advice. And we have 8 nurses that are very, very comfortable talking about this. This is a big part of people's lives. And it is important that you feel comfortable having that discussion. So people who attend cardiac rehab apparently have better sexual satisfaction. And if this is a problem, you can have this conversation with the doctor or the nurse. But when can you resume normal relations with your partner? When you can climb 2 flights of stairs and walk briskly without symptoms of angina. Safety tips: slow down to reduce the workload on your heart. Avoid positions where you're holding up your weight, spoon or snuggling positions with your partner behind your partner, and a healthy partner on top. This is the extent of the sex talk I'm giving you. Okay, I like this section because you're saying to me, you still haven't made a case for me, Michelle. You still haven't convinced me this is what I need to do. Give me numbers. Talk to me about what you're going to do for me and what I can expect if I start and end this program. I may skip a little bit in between, but I'm going to give it my best. What am I going to expect? 25% reduction in mortality. So if we had 8 people in the room, 2 people are not going to die. All-cause mortality, I'll come back to that. We had 10 people in the room, a 20% reduction in hospitalizations. All you have to do was start, keep going, and finish. Okay, so you're changing over time because obviously we're putting you through for months on end, 4 months of an intense and then 8 months of monthly, right? 20% reduction, 1 in 5 people will not be going to the hospital. Why? We'll be dealing with your issues as you come in. It doesn't get out of hand. We actually just deal with it because you'll be telling us about it. So nothing gets blown out. Everything gets handled before it becomes a true problem. Recovery time for the person who had the bypass or the sternotomy, down by 50%. So if you were recovering in 4 months, you're down to 2 now. What are we going after? We're doing 4 behaviors. We're actually going after behaviors. We're not just going after just exercise. But physical activity affects 7 disease states, including cancers. All but 2 cancers are not decreased by exercise. And you're going, geez, you told me that. Now everybody should be exercising. So your next question is, well, why is everybody not in cardiac rehab? Well, only 25% of people show up. If we had 40 people invited, this is not 40 people, right? Not everybody shows up when they ask. They make excuses, or they don't have time, or they've got something going on in their lives. So tobacco, diet, physical activity, and alcohol affect 7 disease states: cardiovascular, cancer, diabetes, respiratory, osteoporosis, oral health, and mental health. This is the slide that gives you the numbers. So if I say, change your diet and follow the DASH diet, and you're going, Michelle, I'm going to give it my best. Keep in mind, this is the part you put in. We ask you to make changes when you come. The doctor's part is to prescribe the medication. Your part is to take the medications and then try and make lifestyle changes. So part of what you're doing here is any effort you put in, you're going to get paid back in dividends. Okay? So you change your diet, you could expect all-cause mortality to go down by 23%. So that may be no visits to McDonald's, maybe the once a year. And then after that, you'll go, why am I going to McDonald's anyways? Because I'll have to exercise more. Reduce your alcohol, your chances of a heart attack are down by 40%. And you're going, but during COVID, Michelle, everybody went up, right? Everyone went to the LCBO. There was nothing to do. I could only sit at home, watch TV, and watch my Netflix. That's all I could do. You increase your physical activity, and guess what? Your chances of a stroke down. So I'm decreasing your chances of a stroke now. And if you quit smoking, you decrease your chances of cancer by 53%, 1 and 2. Those are the best lottery odds you're ever going to get, right? Again, I have to convince you to be open to some changes. So what can we expect in cholesterol? A 24% reduction. Your bad cholesterol, the LDL, 37% reduction. That's almost the equivalent of a pill. 82% reduction in the atherosclerotic plaques. We're actually forming collaterals. We're forming other ways for the blood to go in the heart because you're exercising. You're increasing blood flow within the heart, and a 91% reduction in angina. Now, believe it or not, one of the most effective ways to prevent dementia is actually exercise. Why? You're increasing blood flow to the brain and oxygen to the brain. So it's actually exercise. So even if this doesn't appeal to you, decreasing your chances of having angina by exercising, that should appeal. I mean, not angina, but dementia, that should appeal to you. I'm going to be able, because they talk about doing puzzles. They talk about doing all that. The one for sure that's going to be shown to prove is exercise. Okay? So that walk when it's really cold outside, you're going, I don't want to do it. Get yourself out there. So heart disease is avoidable. Remember, I told you the most important thing you had to take down from this lecture, 90% of your risk, you control. You're in control of that 90. You're in control if you choose to change your diet. You're in control if you choose to take that medication. You're in control if you choose to exercise. That's all you. So you control 90%. But a healthy lifestyle is not deprivation. If I right now offered you an apple pie and an apple, I know what all of you would choose. Eventually, you're going to say to me, Michelle, I don't want to exercise 1 more hour. Give me the apple with cinnamon, and I'll cut it and I'll eat it. And you will choose not to buy that apple pie. And then you say, well, it's not in the house, I can't eat it. So guess what? I'm going to have to make more of an effort. But if I go out, maybe once a year, I can eat it. Okay? You will find ways to bring healthy habits into your life. Now, Dr. Pandy does have a Twitter account. He doesn't do anything political on it. Okay, I know talking Twitter these days is really, really bad. But when new clinical trials come out, he does give that information through clinical trials with Twitter, because that's the easiest way to get it out if you wish to follow him. The last slide I have is we are part of a national registry. Our cardiac rehab program compares our outcomes to the rest of Canada. If another program is more successful in certain ways, we want to compare our data. Your name can never leave because that would be breaching HIPAA. So you are initials and the date of birth, but your name never leaves. But you have to give us permission. So this is implied permission. If you say no, then we won't use you. But otherwise, you're implying we can use your information. And part of that is, well, how many sessions did you attend in cardiac rehab? What was the outcome of cardiac rehab? And then they'll look to see, well, did you ever come back after cardiac rehab? Because like we've had one person that came back and said, you'll never need to see me again, Michelle. I have done this program. I know what I'm supposed to do. I'm going to be out exercising. And then he comes back every once in a while just to stop and to admit and say, see, you haven't seen me. And we're very proud of him. But I want you to keep in mind that we have, remember I told you that UHN Toronto Rehab, Terry Cavanaugh was the physician that developed cardiac rehab for Canada, okay, the program. And he used to run the Boston Marathon with 4 cardiac rehab participants. Anybody who's done a marathon and goes to the Boston Marathon knows you have to hit a certain time in order to qualify to participate in the Boston Marathon. So these are cardiac rehab participants similar to you, maybe not the heart failure ones, but similar to you, that have gotten themselves so physically fit. They all finished, by the way. They all finished the marathon, and like you don't go there and they say, well, I stopped midway through, I'm done. No. They finish. And so some of the things I'm trying to explain to you is you may come out of this better than when you went in. And it's an approach of what am I willing to do? And that comes down to you. So this first lecture is just to give you an overview. It's to motivate you and to explain to you that you have a role in your healthcare.